How's it going, guys? We have a very difficult question for Renal Pharm. Okay. Maybe some of you seen this clip. You're like, Mike, this question's easy. What are you talking about? Relax. Okay. It's a hard question. I'll tell you exactly what we need to know, some high yield points regarding these drugs. Not waste our fucking time. So before we get started, please subscribe to my channel. I really appreciate it. Give the video a like. I really appreciate it. Find me on Instagram at Mehlman_medical, MEHLMAN_medical. The link is down below. Find me on Telegram. Recently created a Telegram group and channel. Links are down below. Now start the clip. 35-year-old man, through history of excessive thirst and frequent urination. Physical exam shows dehydration. BMI is 20. And he has normal serum glucose at 94 milligrams per deciliter. Normal range should be 72 to 99 milligrams per deciliter. Impaired fasting glucose 100 to 125 milligrams per deciliter. 2 fasting glucose measurements, 126 or greater, is diagnosis of diabetes mellitus. Any 1 random fasting glucose, 200 or greater, is diabetes mellitus, or an HbA1c of 6.5% or greater. So this guy does not have diabetes mellitus. Excessive thirst and urination, okay, polyuria, polydipsia. We obviously need to consider diabetes mellitus. His BMI is not elevated, wouldn't be type 2 anyway. Not that type 1's impossible. The point is it's not fucking diabetes mellitus. So he's got elevated serum vasopressin, elevated serum osmolality, decreased urine osmolality. So if we ignore the serum and the urine osmolality for a second, okay, just ignore that. And we look at our serum ADH, which is high. When we think about what ADH normally does, it inserts aquaporins in the apical membrane of the medullary collecting duct, enables free water reabsorption. Therefore, our urine should become more concentrated because we're pulling free water out of the urine, and our serum should become more dilute. Our serum sodium should go down, and our serum osmolality should go down. Well, we look at the serum and urine osmolality here, and it's the opposite of what I just fucking said, right? So we say, well, that's fucking weird. Like, if ADH is high, it's clearly not doing its job, right? So this means we have insensitivity to ADH of the kidney. This is called nephrogenic diabetes insipidus. If we ignore the ADH that I wrote here for high, and we just look at these urine values, diabetes insipidus, where we have dilute urine and concentrated serum, this can be either central or nephrogenic. So central is we're not producing ADH, and nephrogenic is we have insensitivity at the kidney, right? So this is clearly nephrogenic DI, and we say, well, how are we going to treat it? So let's just walk through our answer choices here. Choice A, acetazolamide, wrong fucking answer. This drug classically used for altitude sickness. This will inhibit carbonic anhydrase in the proximal convoluted tubule. This will prevent bicarbonate reabsorption, which will increase pH of the urine and increase volume of the urine. Those arrows are on one of the questions, I believe, online right now for step 1 NBME. And likewise, you would decrease volume of the serum and decrease pH of the serum. Altitude sickness, okay? So when you go to high altitude, lower oxygen tension, you're going to hyperventilate to compensate. That's going to induce an acute respiratory alkalosis, but your kidney doesn't have enough time. It takes at least 12 to 24 hours for bicarb to really change. Kidney doesn't have time to excrete bicarb. So we force some metabolic acidosis by giving acetazolamide. The point is, it's the wrong fucking answer. Choice B, desmopressin, wrong answer. But this is a high yield drug in general when we contemplate diabetes insipidus. Now, let's say I did not tell you the ADH is high here. Okay, ignore that. And we only look at the serum osmolality and urine osmolality. Well, this looks like diabetes insipidus. Okay. But we could say, well, we don't know whether it's central or nephrogenic. We don't know whether it's due to that we're not producing it from the hypothalamus, stored at the posterior pituitary for ADH, or if our kidney's insensitive to it. So what we do is we give desmopressin, which is a vasopressin analog, and if our urinary osmolality goes up, then it means that we had central DI to begin with. That makes sense. And if we give desmopressin, vasopressin analog, and we do not have restoration of our serum and urine osmolalities, then we say, well, the kidney is insensitive to ADH and we have nephrogenic DI. Okay. Choice C, ethacrynic acid, wrong answer. This is an obscure loop diuretic that shows up in one question, I believe, on one of the offline NBME assessments, but this mattered more when the step 1 was numerical. Okay. It's not a sulfa drug. But you should just, even though furosemide is, and It can cause ototoxicity, the same as furosemide. Okay, it's one question. As I said, you could be aware of ethicrinic acid. It's a loop diuretic, but it mattered more when the step one was numerical. Wrong fucking answer. Choice D, hydrochlorothiazide is a correct answer. Now, look, as I said, this is a very difficult Pharm question because if you Google this as to like, wait, what? Why would hydrochlorothiazide treat nephrogenic DI? Literally, the first thing I'll pop up on Google is the mechanism is not fully understood. But this is an answer on one of the NBME assessments. I think it was NBME 7 offline for 2CK. I don't recall exactly. A Pharm question just like this. But the point is, they ask hydrochlorothiazide on NBME for nephrogenic DI. Apparently, one of the proposed mechanisms is if we inhibit the sodium chloride symporter in the early DCT, which is what thiazides do, then that loss of sodium can cause a compensatory increased reabsorption of sodium in the PCT, which can help retain fluid. So if you were to give someone who does not have DI, just a normal person, thiazide, they're going to micturate/urinate more. Okay? But if you give a thiazide to a patient who has DI, that loss of sodium in the DCT can precipitate the PCT reabsorbing more as a compensation, and the patient somehow actually doesn't micturate as much despite being on the thiazide. Okay, fucking weird, as I said. It's not my fucking opinion. It's on the NBME. And you can also give an NSAID. Okay, so an NSAID, decreased renal blood flow. That means ultimately we could decrease the amount of urination that occurs. An NSAID plus a thiazide is the treatment for DI. Very difficult question. Spironolactone, wrong answer, but high yield. It's a potassium-sparing diuretic. Okay, it's an aldosterone receptor antagonist. The way this shows up for renal stuff is if a patient is already on a loop diuretic or a thiazide and needs more fluid unloading, then you can give a potassium-sparing diuretic such as spironolactone, eplerenone, as well as the ENaC inhibitors, amiloride or triamterene. They show up, okay? So you don't want to drop a patient's potassium more if he or she's already on a thiazide or a loop diuretic, okay? So you have to give a potassium-sparing diuretic. This shows up numerous times on the NBME material, okay? Spironolactone or just triamterene, all right? Or just amiloride, all right? And then spironolactone also, you should know that it's anti-androgenic and cause gynecomastia, and that this is also used in advanced heart failure. Okay, so patients, more step 2 now, patients who will be on an ACE inhibitor or an ARB as first line to increase their ejection fraction in systolic dysfunction. And then you can add a beta blocker, and then you can add spironolactone on top of that. Wrong fucking answer. You know the deal. I'm going to continue to make more content. If you like my stuff, subscribe my channel. And I appreciate your time. That's it.